Good morning, everyone. Welcome to our grand rounds at the Osher Center for Integrative Medicine here at Harvard Medical School and Brigham Women's Hospital. We're going to get started in just 30 seconds as people get together. So we'll get started in just about 30 seconds here. So go ahead and grab your cup of coffee or cup of tea, and we'll get started in just a moment. Okay, let's go ahead and get started. Good morning, everyone. My name is Darshan Mehta. I'm the Education Director for the Osher Center for Integrative Medicine here at Brigham Women's Hospital and Harvard Medical School, and also the Medical Director of the Benson Henry Institute for Mind Body Medicine. And it's my pleasure to welcome all of you to our monthly Grand Rounds series. And before we get started and introduce just a few housekeeping announcements, we have our Grand Rounds on the first Tuesday of every month, but as next month it's the holiday. Well, Dr. Levy is well known for his expertise and clinical acumen in integrative medicine, has really led this amazing interdisciplinary team that sits at the Osher Clinical Center for almost now approaching 2 decades, and is really one of the sort of thought leaders in how we think about clinical integrative medicine in the clinical setting. In addition, I'll introduce my other colleague, Dr. Matt Kowalski, who is the Associate Clinical Director for the Osher Clinical Center. And also his expertise focuses on evaluation and treatment of patients suffering with headaches, spinal disorders, myofascial pain syndromes. He's really been a unique provider as a chiropractic care provider working in an academic medical center and really in collaboration with a multidisciplinary team and leading a multidisciplinary team as well. And he's really been a bridge, serves as really this visual bridge between integrative and conventional healthcare. And I will let them introduce our other panelists. So with that, I'm going to turn it over to Don.
Next. Hi, I'm Dr. Don Levy, as Darshan pointed out. What I hope to tell people today is, or hope you come away with the notion that chronic pain is different than acute pain. And more than ever, we need to go beyond the toolbox, because one modality, one needle, one scalpel, one drug will never completely take care of chronic pain. As you can see, next slide, many people are in pain, and it's a common problem, and it's almost always head, neck, above the neck is 2/3 of chronic pain in America. So back, headache, neck, face. And Western medicine, if you were attending our symposium of last month, honoring the 20th anniversary, we talked about Western medicine, and one of the great things about it is it has decided to give up with the wisdom of the body and consider the body instead as a fabulous machine. And machines have broken parts, and when they break, a mechanic comes along and fixes the broken part. That works somewhat well for chronic pain, but for acute pain. But if you try to apply it to chronic pain, something goes wrong. It never fully does the job. And partially because we are living multidimensional organisms, and partly because we need to use the skills of a gardener more than a mechanic. Next. Back pain is an example. This is since it is one of the major forms of chronic pain, our current state of knowledge is most people will get it, most people will recover, but the prevalence of chronic, very impairing back pain is rising, and it costs us a fortune. Next. there was, next slide, there was a symposium held by a guy named Roland Hazard, a professor at Dartmouth back in 2007. He asked all of his colleagues, what's a really important question to answer in the next decade from 2007 to 2017? And they basically said, why is back pain? We're spending fortunes. We've come up with so many logical treatments and we're not getting anywhere. Do we need a completely new paradigm to attack this problem? Next. One of the things they discovered is it's almost impossible to get an anatomically precise diagnosis. That is, 1 in 4 people with back pain will have a herniated disc, and people with no back pain, will have a herniated disc and not have pain. The vast majority of people in pain have no clear anatomical diagnosis. Next. The pain could be coming from any one of these parts. Of course, if you're looking as a mechanic, you're looking for the broken part. Next. Here's some of the list: ligaments, periosteum, dural sheath, joints, fascia. We can't seem to get to the broken part for chronic back pain. Next. One of the best experiments for me to drive this home was about 200 people were treated in a study by Zui in 2013, in which an MRI was performed a year after treatment. Doesn't matter if you had surgery, in order to get in, you had to have a herniated disc and sciatica. And a year later, they just took an MRI of everybody and said, who still hurts? And they couldn't distinguish. The people that had bulging discs were jogging, and some of the people whose discs seemed to disappear were having persistent symptoms. That's amazing. So is there a high-tech cure for back pain? It's probably unreasonable to expect that purely biotechnological intervention. Biotechnological, the broken part approach will not help us for back pain. They came to the conclusion in 2007. Next. So the American College of Physicians, the American Pain Society said, if people don't improve, we should consider some non-pharmacologic treatments that have some proven benefit in 2007. Next. And what they listed were all of these, which interestingly are offered by clinics like ours and others of similar mind. The recommendations were, quote, weak because the evidence is moderate, but enough to put them all on the dashboard here. Next. The American College of Physicians decided to look at this 10 years later. Notice the date, it's now 2017. They said many of the conclusions we came to in 2007 are pretty much the same. We've decided to add mindfulness-based stress reduction, a thing called motor control exercise, MCE, taping, and Tai Chi. Also superficial heat, and they pointed out that an ultrasound or a TENS one did not seem to be very effective. So the Lancet, another group in 2018, looked and said the same thing, basically. I'll just read what's in red there. For the vast majority of people with low back pain, it is currently not possible to accurately identify the specific nociceptive source, in other words, the pain generator, the broken part. Next. Maybe one other problem besides looking for the broken part is when I was in training some years ago, we decided that after I take your temperature and your blood pressure and your heart rate and your respiratory rate, when you check in for visits, we should take a 5th vital sign, pain. And pain should be listed from 0 to 10. And of course, if you have a pain that's above some number, I should fix it. I should fix that broken part, just like I'd fix your blood pressure or your heart rate if it was too fast. Maybe when we started quantifying pain, it might be helpful for post-op or acute pain, but I'm not sure that got us on the right track for chronic pain. Next. So our integrative approach is we have 3 things we try to do. Look for the pain and the suffering that goes with it, choose and coordinate modalities, and then most important, especially nowadays, explain the rationale if we're going to tell you about a mind-body technique. And then I'm leaving all the tools and things for last because the first 3 are most important. Next. Pain is not the same as suffering. Fabulous idea from a guy named Eric Casella, wrote a book that should be required reading for med students for sure. Next. It becomes suffering. If you're in pain, think about it. If it's out of control or if it's overwhelming, you are suffering. You're just lying there moaning. But the next couple are a little different, the next 2. If the source of the pain is unknown, you have this stomach pain and you know it's a kidney stone, okay, it helped. It helped. I know what it is. They're going to take care of it. If it's just vaguely unknown, you're suffering more, even though it's the same exact pain. Or if the meaning of the pain is something terrible, And by the way, we make up these two. We think about what the source is and we have meaning. For example, if you have a herniated disc and it goes down to your toe and it's numb, you might think if I move and I get more pain, I'm going to be paralyzed. Can you imagine if that's what you think the meaning of the pain is? So suffering, every clinician can address suffering. Sean Mackey, a pain management person at Stanford, came up with the Stanford 5. These are every fellow, everybody seeing a pain patient had to ask about the cause of the pain according to you. And what does it mean to you? And what's the impact of the pain on your life? And what are your goals? Big one, by the way. A lot of people think in chronic pain, I want to get my pain to 0. They almost never say that. They just want to be able to X, pick up my grandchild, eat with my family, take a walk. And finally, what do you think is appropriate? Because if you think the only appropriate treatment, for example, is I need an MRI, I better consider or at least deal with that. Next. So we're going to, as a clinic with those things in mind, we try to basically look at a person, think of multiple hands-on modalities, and work with them before we try the biotechnological interventions. Next. And most of those modalities people know about who come to a clinic like ours, they're listed here. I think up top, it's becoming bigger and bigger to have a so-called behavioral, what I call neurocognitive-based MBSR, mindfulness-based stress reduction. There's a new wave of people talking about pain reprocessing therapy, which is not a big difference from MBSR applied to pain, and some of these other modalities you see here. We would try with you. Next. So the last point, if we're going to bring up mind body or brain body, we need to talk carefully about that with patients. Next. We need to explain anything, even if we're using a medication that looks like it might be used for depression, we need to tell them why we're doing this. Next. So when we're advising somebody about mind body, there's 3 things that need to be done. One, you can't not explain how the mind body connection is, or you're going to be told, you're telling me, doc, it's all in my head. And also to assume that one form of mind body is for all is a mistake. So we might discuss things. For example, the person who got upset when they were given nortriptyline, an antidepressant for pain, was completely calmed down when they were told, you know, it reduces pain in rats. It's nothing to do with it, all in your head. Meditation, how might that work? It may modulate the neurotraffic, the pain, etc. There's neuroplasticity, the brain can make new connections. Next. We talked about, we know about, people know about different types of meditation. Next. I want to go through this quick, only to say that they all involve some kind of focusing the attention, some kind of being in the present moment, either with a form of repetition, a mantra, or a return to the focus, or following your breathing. And it's done with a non-judgmental attitude toward whatever you're experiencing. And I will skip these slides. They basically talk, which I can explain to people, how pain actually changes, or meditation changes the structure of the brain too. Amazing. So one of the latest things going on right now, that's a big book, it's popular, it came out last year by Alan Gordon, Pain Reprocessing Therapy, sort of brings together all of those ideas about the mind-body approach to pain and how we can get off the being in fear and on high alert and afraid to move and stop catastrophizing. Next. So the key point to me, purely biotech cure for pain, unlikely. There's not going to be one magic bullet pill device. Relieve suffering, all those questions that people ask regarding suffering that Sean Mackey makes the pain fellows ask. We're going to probably for sure use a neurocognitive mind-body therapy, even if it's some kind of talking people down from the ledge at every single visit. And then we're going to try to be multidisciplinary and coordinated. These are some 2 great books to read about what it's like to suffer in pain and all the things people go through that are not caught usually in the medical encounter. So I want to introduce Joy. Joy has enough problems for us to use her for a weekend of a workshop, but we're going to focus only on this chronic pain. Her probable main diagnosis was a post-viral chronic pain fatigue with chronic fatigue syndrome with myofascial pain. She also was found to have autonomic dysregulation. Now we know that's POTS. She also was found to have a mitochondrial disorder based on a muscle biopsy, which later we're seeing geneticists at Mass General said, no, it's more like Loeys-Dietz syndrome, which is a connective tissue disorder, not important for all of us, except to point out this was complicated. And it ended up with her having myofascial pain day and night and an incredibly bad daily chronic headache. And some of the other issues came about. Next. These were her medications. Joy and I know each other since 2011. And in 2012 or so, I had this list. You can see just the top three on the left: hydrocodone, Savella. Savella, the dose for a large human being is 200 milligrams. She was on 600. Tramadol, Lyrica, and then a whole bunch of other meds were used. Next and last slide about Joy. Currently, she's on just these 6 on the left and a few others for chronic things. Low dose naltrexone, Celebrex, Lyrica, a few other things that have been used in the past. The list on the right was easily a conference in itself, her journey to get off all of those unbelievably difficult to get off of pain medicines. So that's my introduction of Joy. Joy, let you speak now.
Thanks, Dr. Levy, and thank you everyone for having me. It's really a pleasure to be here and to shed some light on my experience with Dr. John, Dr. Kowalski, and just the Osher clinic in general, which was such a departure for me. When I walked into my first visit at Osher, Dr. Levy had a real uphill battle on his hands because I had lost my faith in the medical system in general, been misdiagnosed too many times to count, been in offices where I felt unseen, unheard, my feelings were not validated, and it was one of those things where I just kept sliding farther and farther backwards, and I was making zero progress or momentum forward in a recovery. So I walked in day one, probably the antithesis of the type of patient you would like to see. I was not kind of ready for what Dr. Don put on the table, but for the first time, I was granted like considerable latitude to narrate an accurate portrayal of my history. So I felt so much more secure in exposing my emotions because he was listening to me intently and responding with empathy rather than staring at the screen and not even giving me the time of day and recognizing who I was as a human being. He was just referencing the records as a supplement, but like really zoning in on me, and relied heavily on my perspective as a patient for richer context of my experience in general. And he was just such a refreshing deviation from all of the myopically focused specialists that came before him, because no one symptom or ailment, like my clinical picture was very complicated, but nothing took precedence over the other. Everything was a clue to unravel the mystery behind my body's distress and what was really going on, and identify solutions that would get me to a better place. So I was really like, compartmentalized care had been to my detriment up until that point. So looking at how the internal systems operate in concert was such a unique viewpoint that I really felt like he appreciated the symbiotic relationship between Western and Eastern philosophies, and more than anything else, it was the purity of his intentions as a devoted practitioner and his like unbridled enthusiasm for all different new frontiers of medicine, like bringing new studies or different opportunities for me to try, or options for me to add to my repertoire. It was just such a new take on my case. So that back and forth dialogue really augmented my willingness to be receptive to and later compliant with our joint plan of action, and including natural supplements to enhance or replace my existing prescription regimen was huge. And really that 1 hour evaporated like that, but it was a huge paradigm shift in my perspective on medicine. So it drew an indelible line of demarcation in my recovery. And he really, in that 1 hour, rekindled hope and the prospect of a brighter future, which I had basically given up that could be a possibility. So just not having the symptoms relegated to like separate spheres or addressed in isolation allowed us to access this like fruitful wellspring of information. And month after month, visit after visit, I was able to reclaim control, reclaim my voice. I was emboldened and empowered to advocate for myself, and that trickle down effect in other aspects of my medical care was incredibly important in my recovery. So over the years, he became a loyal confidant, a faithful advisor, a shrewd mentor, like all of these other things, and really my most steadfast champion. But he really, more than anything else, looked beyond the disease to uncover the core of my humanity. And that's what accelerated the reunification of my broken spirit. So I'm just so grateful for his support, and I wouldn't be doing anything that I'm doing today, which I do have a very full, beautiful life that none of it would have been even in the realm of possibility were it not for all the time that we spent together. So it's a great opportunity for me to say thank you.
Just want to make sure my screen is showing. So during the course of Joy's care, we came to the point where he felt that some physical medicine approaches would be appropriate. And understanding that this has been about a 4-year journey to help Joy reduce her medication usage, to start movement, to start actually getting out of her bedroom. And I remember her saying just the other day that she set up her bedroom as her environment, and this is where she expected to spend her days. So when I got to meet Joy, it's a completely different pain profile, and I'll share that with you in just a second. But I stepped in as a chiropractor, and as a chiropractor, what is our role in pain management? And Dr. Levy and I commonly go back and forth about whether I'm actually a mechanic or a gardener. And I think we play both roles. And in the role of in chronic pain, I think a chiropractor can absolutely work in the gardener's role. With our patients, with Joy, and with so many patients in chronic pain, the diffuse pain is just so overwhelming that they feel hopeless, they feel helpless, and they can't figure out the source of their pain. And in Joy's case, her pain became so diffuse that it wasn't really clear to her, to any of us really, where exactly what those pain generators were, or whether this was just whether this was a central pain sensitization profile. But what we can do with manual therapies is to bring attention and awareness to the physical findings that could potentially be alleviated. It's nice as a chiropractor, any therapist who uses manual evaluation and treatments, to be able to put a finger on an area and have the patient identify that area as an area of pain or a pain generator. And we're able to do that with Joy and identify specific areas that could then be alleviated, and give her then a sense of control and reduce that feeling of helplessness. And then slowly just chipping away at the pain from a physical medicine perspective. When I met her, she said, I asked what her goal was, and she said to get off all these medications. And at that time, there was still an impressive list. But what she was starting to do is to get empowered to do so, and to start to actively participate in her care. And then what is it, chiropractor I'd like to do is to introduce self-care strategies to empower the patient early on. And again, my goal is to assist in the reduction of pain medication, but as a chiropractor, I don't advise in reduction or removal of pain medications or any medications. That's in coordination with Dr. Levy or the medical providers. So what is the scope of practice that chiropractors can use? A lot of people think of chiropractors as the spine doctors, the ones who provide spinal adjustments or spinal manipulation. But the scope of practice in chiropractic extends far beyond that. Not only do we perform manipulation, but mobilization techniques, a lot of soft tissue techniques, and chiropractors are also trained in exercise and rehab, posture care, and also training as health coaches, including nutrition and general health coaching. So when I met Joy, it was January of 2015. Her chief complaints were diffuse spinal pain. It was primarily focused on her neck and upper back. She had chronic daily headaches and some intermittent low back pain as well. Her findings were she had this classic sway back appearance, her postural, a lot of postural deviations. She had become very deconditioned. There was diffuse soft tissue tenderness to the point of allodynia, where just light palpation would actually provoke pain. There were multiple trigger points, and I'll explain that in just a moment, throughout her neck and back. And she had a very thin frame. She was low weight and really general kind of joint laxity as well. But there were a number of complicating factors. Joy was dealing with a high stress burden from chronic pain as well as other life events. She had allodynia, so just tenderness where in areas that should not be tender to palpate. She had become deconditioned from years of being sedentary because movement hurt her. And ultimately that led to osteopenia and osteoporosis at this young age. So my goals in treating someone like Joy is, first, don't contribute to her suffering by using alarming lexicon. We can use words that turn into scalpels for our patients. And one of the things that I guess a pet peeve of mine is when my patients come in and tell me that my whatever type of therapist told me that I'm the worst one they've ever seen. How disempowering is that for a patient? I think what we need to do is to build just the opposite and say, no, I've seen plenty of people like you and I'm here to help. We don't want to use words like degeneration and deconditioning. We want to build our patients up with words that actually help build them as well. We want to provide them assurance that the problem is not permanent, that we can slowly chip away. And I can show you how we can slowly chip away by alleviating some of these physical findings. And one of the main goals for me is to assist the patient in actually experiencing the source of the pain without worsening the somatic responses. I want to be able to show the patient that here is where the pain may reside and we can take care of it. Ultimately, I like to improve functional mobility, reduce postural strain, and relieve myofascial pain. I wanted to initiate a physical conditioning program as quickly as possible, but it was beyond my scope to be able to handle the level of care that Joy needed to bring her back into physical conditioning. She was deconditioned, she had osteoporosis, and years years of dealing with chronic pain. So I wanted to help improve her ability to enter into a supervised rehab program, and of course, to reduce her medication usage. As far as the treatment goes, one of the things that Joy expressed to me early on was, is this going to hurt me? Is treatment going to be painful? She had seen demonstrations of chiropractic. She was familiar with spinal manipulative therapy. And she said, is this going to injure me? And what we had to do is reassure her that there's more, that there's care beyond the scope of spinal manipulation to help reduce and alleviate her pain. She wanted to know what the source of the pain was. And commonly in her case, there was pain along the costotransverse joints. There's a lot of myofascial pain in the mid-scapular region. But she also had a lot of myofascial pain that was contributing to her pain profile. So one of the things that I can do as a chiropractor, provide soft tissue therapies, trigger point therapies, and by showing the patient that, hey, if I push on this spot right here and I can reproduce your pain, this is a starting point for me to help reduce it. So as long as we can identify it, we can help to reduce it. The treatments that we included weren't focused on spinal manipulative therapy. The treatments, actually, the manipulations that I administered to Joy were using 2 fingers and pushing on her spine, just using 2 fingers as I palpated along her spine. There were techniques that I used in adolescent patients, but that was for pain tolerance. She was able to tolerate. I also use traction techniques, this technique you're seeing in the center here called flexion distraction. We're applying just gentle traction to her spine to introduce some mobility. And you'll know that a lot of chiropractors do instrumented manipulation. I don't, but this is a technique that can be used that applies a low force mobilization force to the patient's spine, which is very safe and very low likelihood of causing any exacerbation. So we started with graded mobilization before even considering manipulation. Her treatment also included immediate home exercises. We started to do some postural exercises. And one of my favorites is one that's on the screen here, just having a patient overcorrect their posture and starting to retrain a motor engram, so they can actually learn what postural neutrality is, just to activate the muscles to improve their postural control. So just to give you an idea of what Joy's clinical course was, we jumped forward to, it took me from January to August to start to introduce physical therapy. And her goal at that point was to reduce tramadol and sevella. By October, she began aquatic therapy, and a great milestone, she actually jogged for the first time. Yet it was in the water, but here physical therapy was able to bring her forward with a modality that we didn't have available. In October, again, she said she started some overhead presses, and she said, reported that I'm having some good pain. And these were all quotes directly from her. It wasn't until over a year later that I actually started to administer spinal manipulative therapy. So it took a year of manual therapy, physical therapy, conditioning to get her to that point where she could tolerate it. It was wonderful. She began yoga in April of 2016. But still, the suffering persisted. In April of 2016, she said to me, is there any hope of me getting better and getting on with my life? She wanted to attend college and started to, and it was a time now that she can actually tolerate taking 2 college level courses. When she discontinued Lamictal in November, she said it hit her pretty hard, but she was doing real exercise. It was so great to see her actually not just doing postural control work, but actually exercising with weights and resistance, and began attending college in February of 2017, but still noted just holding a tablet or a book caused strain to her neck and back. A milestone for me was in June of 17 when she took a trip to New York to attend a show, which was an event that caused great stress and anxiety for her, but she did it. I think we all celebrated when she returned and traveled to Illinois. Despite a lot of anxiety, later that year did so. She completed her summer courses in August of 2017 and it's continued to reduce her medication usage. And she finally turned the corner on sevella 2 years later. But she said to me, it's heartbreaking to think where I've been for this last 8 years. 2 last things. 2018, we saw Joy start her first job. She went on narcotic taper and now is in a full-time position at Kendra Stott in a very high-powered position, and we're just all thrilled to see her there. So I'd like to shift. Oh, by the way, and also with her physical therapy care, not only did she improve function, but her bone density also increased. So I'd like to give Joy a few moments just to reflect upon the change in the physical care, and then we'll go to Lee Chaves for physical therapy overview.
Yeah, absolutely. Similarly to Dr. Levy, when I walked into Dr. Kowalski's office, I was equally trepidatious and had previous experiences with chiropractic care that left me in bed for a week or, immobilized me completely. I was, my myofascial trigger points were just so tender to the touch that I didn't trust anyone with that part of my body because I just recoiled almost instantly, even when my own mom, tried to, help with the knots in my back, neck, and shoulders, which is like comprise the most problematic region bar none. So I, was only open to it because my mom also saw him and insisted that he was going to be different. And he was, because he was incredibly gentle and similar to Dr. Levy, was looking at me as a whole person and really listening to me. So when I gave feedback that something, was too much, or, we would reduce the pressure the next time or make adjustments accordingly. So every single visit, we were making progress little by little. And that's all I ever wanted. I never walked in hoping for a panacea in any of these instances. I knew I was really down a path where it was going to take a long time for me to get from point A to point B being the desired result at the end. So I was in it for every little baby step, every little victory, and everything working in concert was the secret sauce to my success. So having, Dr. Don's insights while having Dr. Kowalski work on my body while with very gentle manipulation while going back to physical therapy and working on that bone density. It's very jarring at 26, 27 to be told you have osteoporosis. Like, that's not something you anticipate, or to be told that the medication for that, if we wanted to go that route, could render me infertile. So that wasn't an option in my mind. And I was going to work hard in physical therapy and have resources at my disposal that would make me stronger. And every time I had a little victory, it allowed me to challenge those negative thought patterns of I can't, and this is impossible, and I'm never going to get there. It was very small change, one at a time. The same with the medication drops. Like, all of this was happening in tandem, and every part of it was painful. Every part of it exacerbated the pain to a level where, there were days that I certainly wanted to give up, but at the light at the end of the tunnel of like what might be possible if I could think clearly, see clearly, be out of the haze of 24 prescription medications, all causing different side effects, and just really making symptoms worse rather than better. It was incredibly empowering to have these individuals in my corner who really saw me and were rooting for me and supporting me in more than just my recovery in their office or like the strides I was making from a clinical perspective. To Dr. Kowalski's earlier point, like, they cheered me on about, a trip to New York or something that I did that, to put it in context, I spent nearly a decade barely leaving my bedroom, except for going to doctor's appointments. I considered myself a professional patient because that's all I had the energy or wherewithal to do. And I was invested in my recovery. So I put all my energy towards that, but I had stopped living. I wasn't thriving, wasn't flourishing by any stretch of the imagination. It feels so far removed to think back to that earlier version of myself, because today, I just got back from a hiking trip with my sister in the Pacific Northwest. If you had told me even 5 years ago that I'd be hiking in the Hoh rainforest, I would have laughed at you. It's because of providers like the ones before you that really poured into my soul and not just my body, that got me to a place where I am now doing things, contributing to the community through my job. My position at Kendra Scott, I'm a regional marketing and philanthropy lead. So my job is to connect with nonprofits and use our jewelry or a jewelry brand as a vehicle for doing good and serving others. And none of that would be even in my lexicon if it were not for the journey that we're kind of laying out before you. And so I am just endlessly grateful that I finally found people that saw me, heard me, validated me, and were like real cheerleaders and supported my growth and development beyond the illness that had for so long defined me. So.
And an extremely key component of Joy's recovery was her experience in physical therapy. Though we don't have her attending physical therapists with us, we have Levy Chaves, who we asked to share some of their approach, physical therapy approach on someone with osteoporosis and someone with chronic pain. And so I'd like to hand over to Lee.
Thank you. Though I didn't have the pleasure of working with Joy, I figured I would just touch on a few important factors in physical therapy when we're treating patients who have chronic pain. Matt, you can go forward one. So first of all, I think it's most important to develop a therapeutic relationship. The patient needs to trust and have a lot of confidence in what the therapist is doing and having the patient do. Without that, there wouldn't be a lot of progress with moving forward with the therapy. The other factor that's, or within that factor that's important is really having an understanding of the patient's goals. What do they hope to achieve? And I think sometimes as the physical therapist and using some of our knowledge, we can help guide that. We have a lot of patients that might find that just having no pain is a goal. We might need to help guide and coach them that, you know, like what is it, asking them, what is it that you actually want to do, to help guide in making the goals achievable, short-term goals, long-term goals, and then we move forward. We do utilize some of the principles of motivational interviewing to help have the patient understand how they're doing, where they're heading, and really to celebrate the good and even just small achievements. Providing education is really important. And I think as mentioned earlier, we can provide a lot of education regarding anatomy, physiology, biomechanics, pain science, but not everyone wants to hear that or needs to hear that. So as we're moving forward with patients' care, we will try and get an understanding of what the patient would like to know and what sometimes we feel like they might need to know as they're progressing along or having trouble progressing. We need to have them understand the expectations after exercise as they begin, that, you know, it might be okay to feel the soreness, you know, what is okay to continue doing, what might need to be, you know, what the patient might need to rest, and to know that little achievements are important. As far as different exercises, we need to understand how we would determine which types of exercise and the dosage of exercise. So with a patient who has chronic pain, we need to make sure that they just learn how to start moving if they haven't been moving. So we can do simple things, functional movements, you know, basic functional activities like having them walk or you know, empty the dishwasher or anything that they might feel like they would like to achieve. In terms of patients who have osteoporosis, we all know that weight-bearing exercise are most important, but at the same time, if a patient has had chronic pain, the starting a weight-bearing exercise program might not be realistic right away. And that's okay. So we have patients do possibly aquatic therapy, you know, even just light weights, walking. They can progress to higher impact activities to help them develop, increase their bone density. And then the home management is really important. So if the patient has an understanding of what little things they can do at home. And the example I used already was if you empty the dishwasher, that is actually a form of exercise if that's something that you haven't been able to do and something that you would like to do. Managing the pain with either heat or ice, being able to offer suggestions for any form of movement or exercise at home to help keep the body moving. Okay.
I also think we also believe is that you helped treat her osteoporosis. And it's not something that someone would think about too often with physical therapy. Can you make mention of that, please?
Sure. So, you know, in physical therapy, any of the exercises that we're prescribing that include any sort of weight bearing can help increase the bone density. So simply, you know, just any lower extremity weight bearing exercises, starting, like I know Joyce started in the pool and progressed to more land exercises. Small weights, small resistance can help with bone density. So we certainly see a lot of patients who have a combination of chronic pain and bone density issues, or we can see patients who just have bone density issues and give them guidance and exercises to help that.
Thank you. It seems that one of our panelists is not here. I don't know if Dr. Levy, if you can address the topic that Dr. Wang was going to discuss.
I'd be glad to wing it. I think, you know, I hope the flavor of this is coming through, that there certainly are tools. There are particular pills, interventions that are fine, but they'll never do it alone, or they'll do it temporarily, or people will have to come back regularly for those shots, those injections, those pills. And one of the ones that made sense to us is Joy had gotten benefit from narcotics, and everyone knows the problems with narcotics. And so there is low dose naltrexone to be offered. There's a tool, for a mechanical tool. Low dose naltrexone was used when I was in training in 50 milligram tablets to help people get off narcotics. Didn't work too well, I remember, because people just didn't take it and went and got their heroin or whatever they were taking back then. So it disappeared until someone brought it out as a possibility at very, very low dose. And they started at 1 milligram and then 2. This is from a 50 milligram tablet that people might take 1 or 2 a day. And 1.5, 3, up to 4.5 milligrams of naltrexone taken in the evening seem to modify the mu receptor and allow us to release our own endorphin. And I wish Dr. Wang is probably caught up with patient care right now, since he's a pain neurologist. He could explain just how that works, but it's a low dose, less is better, and it seems to work better in the evening, strangely, so that your body has a chance to generate its own endorphin. And Joy could speak in a minute as to whether, you know, how that worked for her. And I'll mention the other thing. Hopefully Dr. Wang can, if he can get here, can talk to us about. She also found one of the offerings from pain management centers, which one of my favorite directors said, a lot of our pain management centers have become block shops. We just do nerve blocks and pills and injections, and we need to do better. We need to do more and hold the whole patient the way Joy described. The IV lidocaine. Lidocaine, people know what that is. You might get similar to Novocaine when you get a tooth extraction. It's also an antiarrhythmic. We used to push it for people who had a heart attack to prevent an arrhythmia. IV lidocaine? Yeah, well, if you get the infusion, it's kind of a difficult experience. Joy would have to go in and spend an hour or 2 there or more with a nurse watching her carefully and get 2, 3, supposed to get up to 4 weeks. She said 2 weeks was great, of significant relief to help get back on, you know, do whatever her life involved. So low dose naltrexone, a non-narcotic, but derived from the narcotic history, and lidocaine, a known anesthetic given in an IV infusion for over an hour or 2, were 2 sort of off the grid, slightly off the grid, but acceptable off-label uses of medications that were, I think they're important to Joy. There's Dr. Wang. Dr. Wang, if you can hear me, Victor, we just spoke a word about low dose naltrexone and IV lidocaine.
Hi. Yeah, sorry. Apologies. I was trying to end the last patient visit, and it was one of those where they wanted to ask a question after another question, and actually it was neuropathy. So I guess it's a little bit applicable. I like
that you actually answered them. That's great.
Well, it took a long time.
Yeah.
What are we talking about? Low dose naltrexone?
And yes, and IV lidocaine. We got to the point where there was 2 things that were game changers for Joy. You know,
okay, yeah,
off-label uses.
About that. Yeah. So yeah, both low-dose naltrexone and IV lidocaine are more sort of on the experimental side. And usually any patient that has, if they're on IV lidocaine, low-dose naltrexone, it's usually because everything else has been tried. What should I start with? IV lidocaine is sort of on the way out, although there's still a lot of people using it, but on the way out only because of reimbursements. IV lidocaine requires a nurse to monitor while the patient's receiving it, because it's an antiarrhythmic, can drop your blood pressure pretty quickly. So having that nurse watching can be quite pricey, especially if reimbursements keep going down for it. But there is some good evidence for IV lidocaine being used. Most of the studies have been used in the perioperative setting, which have been sort of successful but not successful at the same time. They're really looking into it more in the chronic pain field as well. Hopefully that's a little blurb on IV lidocaine. For low-dose naltrexone, that's another thing that's been experimental as well. As you all know, wow, there's like 69 people on this. Just noticed that. The naltrexone, I don't know how much you guys have talked about naltrexone, naloxone before I hopped on. Anything?
Just a couple of words about it and its history as a drug at 50 milligrams for
Oh,
narcotic use.
Okay, because I was about to just talk about that, but I think if that's been covered. More recently, I think it was during the AIDS epidemic, they talked about that somebody started looking at low-dose naltrexone as an immune modulator at low doses, meaning like 1 to 5, I think 1 to 5 milligrams, or a little bit less if I'm not mistaken. But low-dose naltrexone, as you know, naltrexone itself is a mu opioid antagonist, and at low doses they've seen that it can act as an immune modulator. People have looked at the cytokines, and it changes the circulating levels of cytokines. And also the theory too is that at low doses, because it blocks the opioid receptor, it can increase the circulating beta endorphins in the body too. So that's kind of the theory of how low-dose naltrexone works. And they've seen that with low-dose naltrexone, there are lasting effects too. It's not necessarily an acute action that LDN has.
I'm just going to interrupt here just because we have a few minutes left. Just wanted to see if we can ask just a question and answer it briefly. And these will be tough questions to answer briefly, but just to get a couple in. Don, if you can, there's been a couple of questions around understanding what functional medicine is versus what happens at the Osher Center. And it obviously could be a whole grand rounds in and of itself, but is there a short answer that you could provide to understand that difference? Because that's oftentimes many patients with these will often approach functional medicine.
It is a word that seems to be synonymous with integrative, which is one that which sits somewhere in the middle of all the different types of therapies and tries to integrate them. Functional, I think, has two premises: that our body is filled with nutrients and with toxins, and the goal is get more nutrients and get rid of toxins. And how do we do that? We test your urine, your poop, your blood, and find out if you have any toxins or enough nutrients, and then try to balance that. That's my 1 minute. It's not fair because there are huge textbooks of functional medicine. I'm probably insulting all functional medicine doctors, but it is an approach that does look for, I think, more mechanical in a way and physiologic to most problems. Most functional medicine doctors, however, do a lot of what we're talking about here. So that starts to blur.
This question for everyone, I guess, in this way, and maybe Victor, I'll ask first, was that some of, many times people who are dealing with chronic pain syndromes, their course has been complicated by weight gain, potentially by some of the medications that they're on. So how does, when you think about some of these integrative medicine modalities, how do they help patients with some of these side effects? What have you observed?
Well, I mean, with almost any neuropathic medications, there's always that side effect of weight gain, and I think that's one of these one of the difficulties of treating pain, because with pain also at its base, patients aren't exercising or watching their diet necessarily because of the pain. So it's kind of a vicious cycle. It's hard, I think it's one of these where I have to talk to the patient and say, look, pain is something you may have to live with for a while, and I'll try to help as much as I can, maybe with things like low dose naltrexone or other therapies. But yeah, I don't know if others have better answers for that.
Yeah, Lee and Matt, if you want to also, and then Joy, your experience as well.
Well, I can just add, in physical therapy, if that is something that a patient is struggling with, we would work with them to have them do any sort of exercise that can help help them lose weight or control their weight to the best of our ability.
And in our case with Joy, we didn't encounter weight gain issues. We were working on actually increasing weight. So we have nutritionists that we collaborate with as well to get a patient on an appropriate nutrition plan, as well as their movement plan in coordination, be it with physical therapy or trainers as well.
Great. And I'm going to invite Joy into our panel as well. Joy, just any sort of thoughts when you look at this sort of multidisciplinary group of providers, your experience having gone and seen multiple providers, what is sort of a take-home message that you'd want to leave the audience in terms of when we think about this type of multidisciplinary approach to chronic pain?
I would say this approach was marked a watershed in my recuperation, because it took into account the full range of interrelated physical and non-physical factors that influence wellness and disease. So this kind of tailored blend of conventional and complementary and alternative therapies that best served me as a whole person, and honored kind of the biological, psychosocial, environmental, behavioral, and spiritual dimensions of my life. It was imperative to my recovery, and incorporating natural, less invasive remedies, having proactive strategies and self-care being encouraged, whether it was movement, nutrition, the mind-body connection, drawing from all the scientific disciplines and not necessarily being so myopically focused on one problem that needed one solution, but the consistent coordination of treatment paired with compassionate relationships between me and my providers. That's what translated to a more favorable outcome.
Again, so I want to just take a moment to quickly thank this panel, and I hope to the audience, just getting a sense that some of, really takes a team and a team that communicates with each other to really help work with patients who are dealing with chronic medical conditions, especially chronic pain syndromes. I just wanted to remind everyone that our next grand rounds will be on Tuesday, July 12th. This will be given by Dr. Dickerson from Northwestern. And the title is Nature Nurtures, Exploring the Health and Healing Benefits of Being Connected to Mother Earth. So again, would invite you to all, this is a deviation, it's the second Tuesday, and normally because of the 4th of July holiday. But again, thank you again to our panel and to the Osher clinical team for leading this discussion. And again, we look forward to seeing you next time. This was a really wonderful presentation. And thank you, everyone.
Thank you all.